Welcome to this training on mental health advanced directives and outpatient providers. This training is appropriate for people interested in having a mental health advanced directive, care providers, tribal partners, and certified peer specialists and peer supporters. During this session, we will define mental health advanced directives, their components, and why they are important. We will describe how outpatient providers support care with tools like the MHAD. We will explain how outpatient providers and mental health clinics can support clients in using MHADs and why this helps people feel heard, stay well, and avoid crises. And we will learn why outpatient mental health providers should talk about and support MHADs and how this can help people get better care and avoid crises. So let's dive in. This training is about a very helpful tool in mental health care called a Mental Health Advanced Directive, or MHAD for short. An MHAD is a legal document that lets people plan ahead for their mental health treatment. It's used when someone may not be able to speak for themselves or make decisions during a mental health crisis. Mental health conditions can sometimes cause confusion, fear, or stress that makes it hard for a person to think or clearly explain what they need. That's where an MHAD comes in. It allows a person to write down important information ahead of a potential crisis, like what treatments or medications help them, what treatments or medications they want to avoid, and who they trust to make decisions on their behalf if they are unable to. The information in the MHAD can also help a person feel safer and calmer before a full crisis occurs. An MHAD does not just help the person who wrote it, it also helps the people who are trying to support them. Doctors, nurses, therapists, and crisis workers don't always know a person's history or what works best for them. An MHAD gives clear guidance to the care team so that they can make better decisions and respond in the most helpful way, especially during a mental health crisis or when providing help before a crisis. It's important to know that an MHAD is a legal document. That means it has power. It must be taken seriously and included in a person's medical records. Care teams are expected to follow the directions in an MHAD unless there's a very specific reason they cannot. Having an MHAD helps people stay in control of their mental health care even during the hardest times, because it makes sure that others know how to provide support that feels right. MHADs can be a powerful tool for individuals facing mental health challenges. This might include conditions like depression, bipolar disorder, schizophrenia, or anxiety. Any situation where someone's mental health may fluctuate over time. They are also incredibly valuable for people who struggle with substance use, whether that's drugs, alcohol, or both. These challenges can sometimes lead to unpredictable or high-risk situations, especially during periods of crisis. We can't overlook the impact of trauma. People with a history of trauma, whether from abuse, violence, loss, or other deeply distressing experiences, may be more vulnerable when under stress. Trauma can help shape how someone responds to a crisis, and MHADs help ensure that their care reflects that understanding. While these are some of the most common groups who benefit from MHADs, they are not the only ones. There are many other conditions and life circumstances that can increase the likelihood of a mental health crisis, and that's exactly where MHADs come in. They provide a structured, compassionate way for individuals to express their preferences, outline their needs, and ensure their voice is heard. So, when asked who are MHADs for, the answer is anyone who wants to be prepared, protected, and empowered in the face of mental health challenges. An MHAD is a legal document that lets someone plan ahead for their mental health care, especially in case there's a crisis in the future where it may be harder to make decisions or speak up for themselves. To fill one out, a person making the MHAD has to have something called capacity. So, what does having capacity actually mean? Having capacity means that the person is able to think clearly and make decisions about their own care at the time they are making the MHAD. To have capacity, a person has to be able to do three things. First, take in facts about treatment. For example, if a doctor explains 2 different types of therapy or medication, the person can understand what each one is. Next, they have to be able to compare the risks and benefits of those treatments. This means that they can think through what might help them, what might have side effects, and what feels right for them. They also have to be able to say what they want. This could mean choosing one type of treatment over another, or saying they don't want a specific type of care based on their past experiences. It's also important to know that adults are usually presumed to have capacity, so there's no need to prove capacity before making an MHAD. Let's say someone named Jordan is thinking about creating an MHAD. Jordan has a mental health crisis as a young adult that resulted in his involuntary psychiatric hospitalization. He was diagnosed as having schizophrenia and began treatment with medications that have helped him. When he returned home from the hospital, Jordan completed an MHAD with the help of a local peer specialist. Under Washington law, it is presumed that Jordan has the capacity to complete his MHAD, and his MHAD is presumed to be valid. His diagnosis and hospitalization do not change that. If he has another crisis, providers must honor his MHAD. Washington State allows youth ages 13 and older to make their own MHAD if they demonstrate that they are able to make an informed decision about their behavioral health care. That's because in Washington, teens have a right to make some of their own choices about mental health care. So if a 13-year-old knows what helps them during a mental health crisis, they can complete an MHAD to make sure those preferences are honored. Now let's break down what's inside an MHAD and why each part matters. An MHAD usually has, at minimum, 2 important sections that work together to help someone stay in control of their mental health care. The first part is advanced instructions. This section is all about writing down the person's preferences, the things they know from experience help them, and the things they want to avoid. This could include medications or treatments that they consent to or that they refuse, life responsibilities like making sure someone checks on their kids, pets, or home, or who should help with bills when they're in the hospital. These instructions are personal and powerful. They help doctors, nurses, and crisis teams understand the person as a whole and give care in a way that works for the individual. The second part of the MHAD is called the healthcare power of attorney. This is where the person can name someone they trust to make decisions on their behalf if they are not able to do it themselves. That person is called an agent. Now here's something really important. Choosing an agent is optional. A person can still fill out an MHAD with just their advanced instructions, and that document will still be valid and helpful. But having an agent can make sure things go more smoothly, especially in fast-moving situations where decisions need to be made quickly. Together, these 2 pieces make sure that a person's voice is still heard, even if they cannot speak up for themselves. And that can make a big difference in how safe, supported, and respected they feel during a mental health crisis. When someone creates an MHAD, they're building a personalized guide for how they want to be treated during times when they may not be able to speak for themselves. MHADs can include a wide range of care instructions, each one helping to shape a more responsive treatment plan. For example, a person might describe their mental health condition in their own words, noting what treatments have worked well for them in the past. Someone might write, "When I start feeling overwhelmed, I respond best to quiet environments and low lighting." These types of insights help providers tailor care to what's actually effective. MHADs also allow individuals to express clear preferences about medications. They can give consent for specific treatments, like I authorize the use of Risperdal if I start experiencing hallucinations, or refuse others, such as I formally object to the use of Haldol. It causes severe side effects for me. Support systems are another essential part of an MHAD. A person might identify someone to call in a crisis. They could say, "Call my friend Keisha. She knows how to help me calm down," or name trusted medical providers they want involved in decisions. This ensures continuity of care and builds trust. Note that the proper releases of information must be signed and completed and present for care providers to be able to make outreach. For those in tribal communities, MHADs can include culturally grounded care preferences that might mean involving tribal health providers or community leaders or requesting traditional practices as part of their support. These components are the core of an MHAD. They turn a legal document into a living expression of someone's voice, values, and vision for their care. When discussing MHADs, it's critical to recognize the unique considerations for American Indian and Alaska Native communities, especially here in Washington State, which is home to one of the largest American Indian and Alaska Native populations in the country. MHADs are designed to center the individual's voice in their mental health care. But for tribal members, that voice is often deeply rooted in community, culture, and tribal sovereignty. So when creating and using MHADs, work to prioritize cultural responsiveness as a foundational principle. Let's break this down into several key areas. First is tribal sovereignty. Tribal nations are sovereign governments with their own laws, healthcare systems, and protocols. That means that MHADs must be developed and implemented in ways that respect tribal authority. For example, if a tribal member receives care on tribal lands or through tribal health clinics, their care should be approached in relation to that jurisdiction. Coordination between state systems and tribal entities is essential to ensure that these directives are valid, actionable, and culturally appropriate. Next is identification of tribal affiliation in connection to Indian healthcare providers. A person can use the MHAD form to identify if they are affiliated with a tribe and/or receive care through tribal healthcare providers, also known as Indian healthcare providers. This information can help connect the individual with their tribal community and healthcare providers supporting their care. Next is connections to tribal cultural teachers or community providers. Mental health care is not just clinical, it's also relational. Many tribal individuals rely on extended family, elders, spiritual leaders, and community members for support. MHADs should reflect these preferences by naming who the person wants involved in their care. This might include a tribal behavioral health provider or a cultural practitioner. Including these voices ensures that care is grounded in relationships that foster healing. It's also important to identify traditional, cultural, or spiritual practices that are important to the individual. Western mental health models often focus on diagnosis and medication, but in many tribal communities, healing is holistic. It may involve ceremony, connection to the land, storytelling, or traditional medicine. MHADs should allow individuals to include these practices as part of their treatment plan. For example, someone might request access to a tribal healer during a crisis. Incorporating tribal-specific considerations into MHADs can honor the sovereignty, dignity, and cultural identities of tribal individuals. This helps move from a one-size-fits-all approach to one that truly meets people where they are. Next, let's dive a little deeper into what an agent is in the context of an MHAD. An agent is someone a person chooses to be involved in their care and/or to make decisions for them. The agent is like a trusted spokesperson. They help make sure the person's voice is still heard, even when the person cannot speak for themselves. The agent does not make decisions based on what they think is best. Their job is to follow the instructions and honor the preferences that the person wrote down in their MHAD. The agent can only make decisions for a person if the person has been determined to lack capacity by a professional. Once the person regains capacity, they are in charge of their decisions again. Choosing an agent is optional. A person is not required to name an agent in their MHAD. If someone does not want to choose an agent, they can still write care instructions that providers will follow during a crisis. However, some people feel more comfortable knowing that someone they trust is able to step in and help speak for them. If a person wants to name an agent, it should be someone they trust deeply, someone who understands their values, will support their choices, and is willing to advocate for them when things get hard. For example, a good agent might be a close friend, a family member, a partner, or even a peer support worker. Someone who knows the person's history and truly wants what's best for them based on the person's own wishes. The agent must be willing and able to follow the directions in the MHAD. That includes what treatments the person does or does not want, who they want involved in their care, what helps them in a crisis, and any other instructions that they've written. Where there is a question about what's written in the MHAD or where a decision is not covered specifically, the agent should do what they think the person would want. To officially name an agent, the person must include them in the power of attorney for mental health care form. This is usually included at the end of the MHAD form. Now let's talk about the role of outpatient behavioral health. Outpatient mental health providers are often a primary source of support for individuals living with mental health conditions. They are the people individuals turn to week after week, month after month, throughout the long process of healing, growth, and recovery. This consistent relationship gives outpatient providers a powerful opportunity to make a lasting impact on a person's well-being. Outpatient teams build long-term trusting relationships. They often work with individuals for extended periods, sometimes for years. This ongoing connection means they get to know the person beyond just their symptoms. They learn about their hopes, strengths, and stressors and support systems. This foundation of trust makes it easier to have honest conversations, make shared decisions, and adjust care over time. Outpatient providers support people through everyday challenges. While crisis teams in hospitals respond in emergencies, outpatient providers help people navigate day-to-day ups and downs of living with mental health conditions. They help manage stress, improve coping skills, and address issues that can affect recovery, like housing, relationships, employment, or trauma histories. Outpatient providers help people stay stable and reduce the need for emergency care. By providing regular therapy, medication management, skills building, and support, outpatient teams can help people avoid future crises or hospitalizations. Their work promotes continuity, safety, and confidence in the care process. Outpatient providers guide people through the different stages of recovery. Mental health recovery is a journey. It's not always predictable, and people's needs and goals change along the way. Outpatient providers help individuals adapt, set new goals, and adjust their treatment as they grow. They are a steady support during times of transition, like after hospitalization, changes in medication, or life events. Outpatient providers also coordinate care across systems. Outpatient teams often serve as the home base for someone's mental health care. They help connect the dots between different providers, such as psychiatrists, case managers, crisis responders, and primary care doctors. They can advocate for the person, explain care preferences, and make sure that everyone involved is working together in a spirit of recovery. Outpatient providers are the bridge between crisis and stability, between short-term care and long-term wellness. Their role is about building a relationship, understanding the whole person, and walking with them as they work toward a better quality of life. When a person has an MHAD in place and it's used appropriately, it helps build a stronger, more trusting relationship with their care provider. That's because the provider is demonstrating that they are taking the time to listen and honor the choices of the person. The person has taken time outside of a crisis to explain what works for them and what does not, and what they hope for if they ever face a mental health emergency. As a provider, following that plan shows respect. And when people feel respected, they are more likely to trust the provider, open up, and stay connected to care. MHADs can also reduce the number of times people are forced into care they didn't choose, like being hospitalized or medicated without their consent. When there is a plan that outlines their wishes, providers are more prepared to offer the kind of support people actually want. This helps prevent the situation from escalating and helps avoid decisions that feel traumatic, unnecessary, or out of alignment with their values. Another major benefit of an MHAD is that it helps ensure a better match between the types of medication people want and the medicine that they get. Maybe they've had bad side effects in the past. Maybe one medication helps them feel calm, while another makes things worse. When providers know that in advance, they can help offer treatments that are more likely to be accepted and effective. This saves time, reduces frustration, and improves outcomes. An MHAD also shows us what really matters to the person, like what helps them feel safe, who they want to be contacted, and what words or actions might make a situation worse. This can make someone feel truly seen and heard, especially during moments when they're scared or overwhelmed. And when people feel listened to, they are more likely to participate in care. Another big factor is fewer mental health crises. When providers know how to respond in a way that honors the person's preferences, it can stop things from escalating. An MHAD can help to catch warning signs early, respond in ways that de-escalate rather than inflame, and avoid emergency responses that may feel threatening or harmful. Finally, when people feel like they have a say in their care, they're more likely to feel satisfied with the help they receive. That means fewer complaints, fewer dropouts, and more success stories. Providers also benefit. When providers can work with a clear plan, they can feel more confident, more aligned with the person's needs, and more effective in their role. Keep in mind that MHADs are not just another piece of paperwork. They are a powerful tool for improving communication, trust, and care. They help providers do their job better and help people feel like they matter, even in their most vulnerable moments. Outpatient behavioral health providers are uniquely positioned to ensure that MHADs are created, reviewed regularly, and put to use when needed. Their long-term relationships with clients and their role in ongoing treatment planning make them an essential part in making sure MHADs are used in a person's recovery journey. When outpatient providers are actively involved, MHADs are more likely to be shared, understood, and respected across the care continuum. Outpatient teams can help strengthen the use of MHADs across systems by distributing copies to the right people, ensuring that crisis teams, hospitals, emergency contacts, and other relevant providers have up-to-date copies of the MHAD so that the person's preferences are available during a crisis. They can help confirm that the MHAD is valid and complete, reviewing the document to ensure it has all required elements such as signatures, notarization, agent designations, and helping the client complete missing sections if needed. They can help by coordinating releases of information, working with the person to sign appropriate releases of information so that the care partners are legally allowed to receive and act on the information in the MHAD. They can also help educate other providers on MHAD content, sharing key information from the MHAD with other members of the care team and helping them understand how to honor the person's stated preferences is very, very important as well. They can also help engage the person's natural support systems, involving trusted family members, friends, or chosen supporters in conversations about the MHAD so that they can advocate for the person when needed and understand how to support the recovery. By playing an active role in these areas and helping complete the completion of MHADs, outpatient providers help ensure that the person's voice is present even during moments when they may not be able to think clearly or speak up for themselves. This strengthens care coordination, supports client autonomy, and helps reduce the risk of unnecessary or unwanted interventions during crises. Let's talk through a few legal considerations. When does an MHAD become active so it can help guide the person's care? When someone fills out an MHAD, they get to choose when it becomes active. That means they decide the point at which the MHAD starts guiding their care, and if they've picked an agent, when that agent can begin helping with decisions. There are three main options for when an MHAD becomes active. The first option is when the MHAD is signed. This means the MHAD goes into effect right away, as soon as it is signed by the person and either a notary public or two adult witnesses. This does not mean the person is giving up control. They still have capacity and they are still in charge of their care. They can make their own decisions just like before. If they've chosen an agent, this option allows that the agent is able to be involved right away. They can talk with the person's mental health or medical providers, review the person's records, and help the person think through choices and give support. This might be a good option for someone who wants help navigating care now, not just during a crisis. They may not be in crisis, but they want their agent to have access to support them in planning, attending appointments, or staying on track. This can be helpful, especially if the agent is actively informed of the person's care and has up-to-date detailed information if a crisis occurs. Also note that if a person does not need help now, this option can help a person reduce barriers for the agent's authority when a person is in crisis, since it does not rely on a healthcare provider to determine if a person is incapacitated. The second option is that the MHAD goes into effect when the person is found to be incapacitated. And this occurs if and only when a healthcare provider determines the person no longer has capacity. This means a doctor or a mental health professional would need to evaluate the person and determine that, for now, they are not able to make informed decisions about their care. At that point, two things happen. The instructions in the MHAD must be followed by the care team. If there's an agent named, their legal authority begins. They can now make decisions, speak for the person, and help the person get the care they need and that they listed in the MHAD. Before that moment, while the person still has capacity, the agent cannot step in. They do not have the power to act or make decisions until the provider makes that formal determination. So a person might put in their MHAD, if I'm in psychiatric crisis and have been deemed incapacitated, I want my MHAD to activate and my agent to take over only then. This option gives some people comfort because they can keep full control of their care until they truly cannot speak for themselves. The third option is when certain events or conditions happen. This gives people even more flexibility. They can say in their MHAD, my MHAD should go into effect when certain things start happening, and then describe those things. These are trigger events that can be anything the person knows are signs that they're heading into a crisis or starting to struggle. For example, they might say, when I stop sleeping for more than 2 nights, if I stop taking my medication and start isolating from everyone, if I become verbally aggressive toward family, that's when I want my MHAD to go into effect. But this option requires something else too. The person must say who gets to decide when these signs are happening. This could be a family member, a friend, a therapist, or someone else they trust. For example, they may say, if my sister sees that I've been hearing voices and not taking my meds, I want her to let my provider know that it's time for my MHAD to be used. This option works well for people who may not want to wait until they're formally declared incapacitated, but who want to catch the crisis earlier before things get too overwhelming. So, which option is best? There is no right or wrong answer. It's all about what feels right for the person and what helps them feel most supported and safe. Some people want their MHAD to be active right away so their agent can be involved as a support partner from day one. Others want to wait until they truly lose the ability to speak for themselves. And some people know the early warning signs of a crisis and want their MHAD to activate when those signs start to show up. No matter which option they pick, the most important thing is that the person has a plan that reflects their wishes and that the providers and supporters follow it. Under current legislation, providers are required to follow and honor the MHADs to the fullest extent possible. That phrase, fullest extent possible, is key. It means that, in general, a person's documented preferences for their mental health treatment must be respected and implemented. However, there are specific exceptions built into the law. These exceptions are safeguards. They exist to ensure that care remains ethical, legal, and safe for everyone involved. Here are 4 conditions under which a provider may decline to follow an MHAD. The first is if following the directive would violate the accepted standard of care, meaning it would go against what is professionally recognized as safe and effective treatment. Then providers are not obligated to comply. If the requested treatment would violate the law, the provider must refrain. No directive can override legal statutes. If the treatment was specified in the MHAD simply is not available, whether that's due to facility limitations, staffing, or resources, the provider cannot be expected to deliver it. In cases of emergency, if following the MHAD would endanger the life or health of the individual or others, the provider has the authority to act outside the directive to protect safety. It's important to note that Washington legislature intends that failure to follow these guidelines can be grounds for a civil claim and for disciplinary action in regard to the provider's license. So, while MHADs are powerful tools for self-advocacy and planning, it's important to understand that they operate within a framework of clinical judgment, legal compliance, and real-world feasibility. Ultimately, the goal is to balance respect for the individual, their autonomy, with the responsibility to provide safe, lawful, and effective care. It's also important to talk about what happens when a mental health crisis escalates to the point of hospitalization under the Involuntary Treatment Act. In these situations, the individual's MHAD may not be followed. This is because the legal framework of the Involuntary Treatment Act can override the preferences laid out in the MHAD. Specifically, if a provider determines that the preferences in the MHAD are inconsistent with the purpose of the commitment or with any related court orders, the MHAD is considered invalid for that period of time. That means the provider is not legally bound to follow it. However, even when the MHAD is deemed invalid, it still holds value. Providers can use it to advise treatment decisions, offering insight into the individual's preferences, history, and what's worked for them in the past. Ideally, the MHAD should be used before a crisis reaches the level of involuntary hospitalization. When implemented early, the MHAD can help de-escalate a situation and guide care in a way that aligns with the person's wishes, potentially preventing the need for the Involuntary Treatment Act intervention altogether. An MHAD also does not give the agent the power to admit a person into a hospital over that person's objection unless it's consented to in the MHAD. Only a judge or certain laws can decide when someone has to be admitted against their will. The agent can help speak on the person's behalf, but they cannot make that type of decision alone. Note that in Washington state, a person can give the agent the power to admit them to a psychiatric hospital when they lack capacity, even if they are refusing. In order to be hospitalized, the person has to have an evaluation and meet the medical necessity requirements for admission. So where do MHADs matter in outpatient treatment? Outpatient mental health providers play a critical role in supporting people over time. They are often the most consistent point of contact for individuals navigating mental health challenges. Because of this, outpatient teams are in a unique position to support the use of MHADs as a tool for preventing crisis and supporting recovery. MHADs can promote wellness and stability in the following ways. First, they can support ongoing safety planning. MHADs build on the work providers already do when helping clients create safety plans. They capture detailed information directly from the client about what early warning signs to watch for, what helps them de-escalate, who should be contacted in crisis, and what treatments or settings feel safest. Individuals may choose to include copies or content from safety plans in their MHADs or vice versa. This kind of planning allows outpatient providers to tailor their support in ways that align with what the client already knows works for them. For example, if a client writes in their MHAD that texting my sister calms me down, the provider can incorporate this into safety planning conversations and documentation. MHADs also help stop crises before they start. By regularly reviewing the MHAD and talking about it during sessions, outpatient providers can recognize when a person's symptoms are beginning to worsen. This gives the provider and client a chance to act early, such as adjusting services, involving support people, or introducing calming strategies before the situation becomes a crisis. For example, if a client's MHAD says they tend to stop sleeping or isolate themselves before a crisis, the provider can watch for these signs and respond proactively. If the MHAD includes a list of helpful coping activities, the provider can encourage the client to use these early on, before hospitalization becomes necessary. The MHAD also gives treatment teams clear guidance about what helps. When a person enters crisis services or inpatient care, outpatient providers can help ensure their MHAD travels with them. MHADs offer specific person-authored directions that can reduce confusion or disagreement among providers, clarify which approaches have worked in the past, prevent unnecessary or harmful interventions. This can all lead to better coordination across systems, more respectful care, and improved client satisfaction and outcomes with services. When a client experiences a crisis or is hospitalized, it can be a very vulnerable and disorienting time. Outpatient mental health providers can play a critical role in helping ensure that the care they receive during a crisis aligns with their values and preferences. If the outpatient team is notified that a crisis event or hospitalization has occurred, they can take several helpful steps to promote the use of the MHAD. They can share the MHAD with emergency departments or inpatient units. Outpatient providers can help ensure that the MHAD is seen and used by the crisis or hospital team. This might include faxing or securely emailing a copy of the MHAD to the facility, uploading the MHAD into a shared electronic health record if systems allow, or making sure that the person's chart clearly notes that an MHAD exists and is legally valid. They might say, I'm calling from the outpatient clinic. The client has an MHAD on file, and we'd like to make sure it's reviewed by the treatment team. They might also contact the person's designated agent. If the MHAD includes a named agent, the outpatient team can reach out to the agent to notify them of the crisis, make sure they have a copy of the MHAD, and offer support or help them connect with the hospital team if needed. They might call the agent and say, we understand your loved one's in the hospital. They've listed you as their agent. Here's a copy of their MHAD in case you need it. They might also provide education about the MHAD to crisis or hospital teams. Outpatient providers may be more familiar with the MHAD than the hospital staff, especially if they help facilitate its creation. They can briefly explain what an MHAD is and why it matters as a legal document. They can point out the person's key preferences written in the document and encourage the team to honor these preferences as part of the treatment team. They can also advocate for the MHAD to be used in treatment planning. Even if a hospital or crisis team hasn't used MHADs regularly in the past, outpatient providers can still advocate for its importance. This might involve reminding the team that the MHAD is a legal tool that should be followed when possible, asking about how the preferences in the MHAD are being incorporated into care. They might say, the client's MHAD says they prefer music therapy and to avoid certain medications. Is the team able to include these preferences in their plan? When outpatient providers stay involved during a crisis, they help ensure continuity of care, promote person-centered treatment, and reinforce the client's right to make decisions about their mental health. These small steps can make a big difference in how a person feels respected and supported. Now let's talk through outpatient teams and MHADs. It's important to know that completion and use of MHADs is supported at a federal level. At this time, Medicaid regulations require both outpatient and inpatient mental health facilities to inform new patients about advanced directives, including MHADs. This could look like asking a person whether they have an MHAD currently in place, explaining the benefits of having one, and/or helping with facilitating completion of the form. Medicaid also reimburses providers for counseling patients about MHADs, whether or not they assist with the completion of the legal forms. This helps solidify the incorporation of the MHAD into the service delivery done by this type of provider. Outpatient treatment teams work with people regularly, week after week, month after month. That gives them something really valuable: time. Time to build trust, time to notice changes, time to have conversations when things are calm. This makes outpatient providers a great partner in helping someone think through and complete an MHAD. When someone is in a stable place emotionally, they can think more clearly and talk about what works for them, what doesn't, and who they want to help speak for them if they're ever in a crisis. That's the heart of an MHAD, planning ahead while someone is doing okay so that their voice is heard, even if they're struggling later on. For example, a therapist might say, if you ever had to go back into a hospital, what would you want the staff to know about how to help you so that you would feel more safe? That kind of question can lead to a really helpful conversation about the person's need, and that conversation can become part of their MHAD. Outpatient providers also support people both before and after a crisis. They may be the ones who notice signs that someone is starting to struggle again, and they are often the team that helps the person recover after a crisis is over. Because of this, they're in a great position to talk about what went well, what didn't, and how to update the MHAD to make it more helpful next time. Another reason outpatient teams are so important is because they understand what services are available in the local area. That means they can help the person write an MHAD that's realistic. For example, it's not helpful to say, I only want to go to Riverview Hospital if that hospital is 3 hours away and won't accept their insurance. Outpatient providers know which programs, medications, and supports are available, and they can help make sure the MHAD includes options that will work for the person. Also, these teams see the person regularly. That means that they can break the MHAD process into smaller, more manageable steps. They can check in on appointments, help fill out paperwork, or connect someone to a trained MHAD facilitator. Completion of an MHAD doesn't all have to happen at once, and outpatient teams can make sure it actually gets done. Finally, people's lives and needs change. So do their MHADs. Maybe someone starts a new medication, loses a support person, or has a different experience in a hospital that changes their mind about what they want. Outpatient teams can help review and update MHADs regularly with the person and make sure new copies are shared with the right people. Outpatient providers play a powerful role in helping people learn about and complete their MHADs. Many people receiving outpatient care have never heard of an MHAD. That means the outpatient team may be the first to introduce the idea and explain what it's all about. This is a great opportunity to build trust and help someone feel more in control of their care. A good way to start the conversation might be, have you ever thought about what kind of care you'd want if you were in a crisis and couldn't speak for yourself? Or have you made a plan for how you want to be supported when things feel really hard? Sometimes people feel nervous or unsure about creating an MHAD, and that's normal. They may ask, what if I change my mind later? Or will anyone even follow this? They may also worry about people disagreeing with what they've written. Outpatient providers can help by creating a safe space to talk about these concerns. They can respond with phrases like, you can update your MHAD whenever you want. Or let's talk about who should have a copy so it's more likely to be followed. Validating concerns and offering clear answers can make a big difference. Outpatient providers can offer practical help with completing an MHAD. That might mean giving the person time during sessions to fill out the form, helping them think through what to write, or helping them complete the form themselves. Asking questions like, what do you want your care team to know if you're in a crisis? Who do you trust to help make decisions if you're not able to? They might also help print copies and walk through it together. Overall, teaching about MHADs is about being present, informed, and supportive. It's about helping make sure the person doesn't have to figure everything out alone. When outpatient providers take the time to talk about MHADs, listen to concerns, and walk alongside the person, it can lead to better care, fewer crises, and more peace of mind for everyone involved. When it comes to completing an MHAD, people do not have to do it alone. In fact, one of the best ways to make the process easier and more successful is to connect the person with someone who's trained to help. This person is called a facilitator. The person helping complete the MHAD does not have to be trained. A person can fill out an MHAD on their own or just with someone they trust. But a trained facilitator can explain what each part of the form means, talk through choices, answer questions, and help the person think through what they want and need during a mental health crisis. Sometimes people are nervous about writing their wishes down, especially if they've had bad experiences in the past. A helper who is calm, respectful, and knowledgeable can help make a huge difference. They can turn a stressful task into something empowering and supportive. Outpatient programs are in a great position to offer this kind of help. Some programs choose to train their own staff to walk through the MHAD process. That way, when someone's ready to create an MHAD, the support is already built into the care team. Staff who know the person really well can help make sure the MHAD reflects what really matters to them. It's also important to think about partnerships in the community. There may be local organizations like peer-run programs, disability rights organizations, or legal aid clinics that already help people with MHADs. These groups might be able to train providers, co-host workshops, or even meet with people one-on-one. Some communities are creating a network of trained MHAD facilitators, so no one has to wait too long to get help with completion. Let's think through some ethical considerations. It is essential that staff helpers never pressure the person to make choices based on what the helper wants or believes is best. The MHAD is a legal document that reflects the individual's own values, preferences, and lived experiences. Any attempts to steer decisions toward the facilitator or the staff person's opinions undermines the purpose of this directive and can compromise trust. Helpers must never use the MHAD process to try to get someone to choose their own programs or services. That means if a helper works for a specific mental health agency or clinic, they should not try to steer the person toward picking that agency just because it's where they work. The MHAD is about the person's choices, not the helper's job or business. Trying to influence their decisions for their own benefit is unethical and inappropriate. If a helper is connected to a program, it's important to be clear and honest with the person about the fact that there is no pressure for the person to choose services that program offers. A good helper might say things like, "You don't have to pick this agency just because I work here. Let's talk about what places you trust or have had good experiences with." Or, "The MHAD is about what works for you, not works for me or my job. You're in charge of what goes into this plan." Or, "I can tell you what this program offers, but you're the one that gets to decide if it's something that you want or not." These kinds of statements help the person know that they are in control and that their preferences are the priority. Helpers must also be mindful of subtle forms of influence like body language, tone, or repeated suggestions. Even well-intentioned comments like, "Are you sure you don't want to include Dr. Lee? She is really good," can feel coercive if the individual is unsure or vulnerable. The MHAD process should be empowering, not directive. Helpers are there to listen, reflect, and document, not to decide. Upholding this boundary is especially important when personal relationships are involved, as the lines between support and influence can easily blur. Ultimately, the helper's responsibility is to protect the integrity of the MHAD and ensure that every decision made within it belongs solely to the person completing it. Now, how can we best promote the use of MHADs? For MHADs to truly make a difference in people's lives, everyone involved in behavioral health care must understand what they are, why they matter, and how to use them in real-world situations. This is about building the skills and confidence needed to integrate MHADs into everyday care. Here are the key areas that staff should be trained in. First is the purpose of MHADs. Staff should understand that MHADs are a way for people to share their voice ahead of time. They let someone clearly say what works for them during a crisis, what helps, what doesn't, who they trust, and what kind of care they want. They should also know about the impact of MHADs on care and outcomes. MHADs have been shown to reduce unnecessary hospitalizations, increase satisfaction, and improve alignment between the care a person wants and the care they receive. Training should include examples and stories that can show how MHADs improve safety and reduce trauma during crises. They should also be trained on the provider's responsibilities to follow MHADs. Staff should learn that MHADs are a legal document in many states and must be treated seriously. Training should walk through examples like, what if an MHAD asks for a specific hospital that's full? Or what if a calming technique is unsafe at the moment? They must be trained on how to navigate conflicts with MHADs. Sometimes the person's families, care team members, or even the person themselves may say something different than what's in the MHAD. Staff need tools to navigate these moments respectfully, prioritize the person's documented wishes, and involve the agent when needed. They should be trained around the role of mental health agents. Staff should understand who the agent is, how they're chosen, and what their role is. This includes knowing when to involve the agent, how to contact them, and how to respect their authority while still listening to other supporters. They should be trained in the facilitation of MHADs, especially positions like peers, case managers, social workers. Training should include how to support someone in creating an MHAD. This could involve using a structured guide, asking questions that help the person reflect, and helping them share their completed MHAD with their care. Teams should be trained on tribal sovereignty and care for tribal populations. Tribal nations are sovereign governments with their own laws, healthcare systems, and protocols. That means MHADs must be developed and implemented in ways that respect tribal authority. For example, if a tribal member receives care on tribal lands or through a tribal health clinic, their case should be approached in relation to that jurisdiction. Coordination between state systems and tribal entities is essential to ensure that directives are valid, actionable, and culturally appropriate. Teams should also be trained in cultural humility in the world of MHADs. MHADs must be built and honored in a way that reflect each person's unique cultural background, values, and ways of communicating. Staff should be trained to ask open-ended questions, avoid assumptions, and understand how identity and lived experience can shape preferences about care, safety, and support. For MHADs to truly improve care, agencies must go beyond education. They must build clear, consistent systems that support their use at every step of a person's journey. That includes onboarding, documentation, crisis response, and transitions of care. Let's break down what behavioral health agencies should do. They should educate staff and clients about MHADs. Agencies should provide regular training for staff on what MHADs are, how they work, and why they matter. This includes helping staff feel confident of talking with clients about MHADs and encouraging their use. For clients, information about MHADs should be shared in easy-to-understand language during orientation, treatment planning, and/or wellness check-ins. Agencies should facilitate completion of MHADs. They should offer direct help to clients who want to create or update an MHAD. This could include trained peer specialists, case managers, or clinicians walking through the MHAD form together, offering private spaces for reflection, helping connect people with notaries or witnesses if needed. Agencies should also work to make sure there's processes in place to store the MHADs. Once completed, MHADs need to be stored where staff can access them easily, ideally in the person's electronic health record with clear labeling. For example, the EHR may have a special Advanced Directives tab or an alert that flags when an MHAD is on file. They should also share MHADs with other providers. MHADs are most useful when shared across systems. Agencies should have protocol for sending copies to crisis teams, emergency rooms, inpatient hospitals, outpatient providers, or support workers. Note that it's important to always make sure the client has given written permission and signed the appropriate releases of information and that the agency is following HIPAA guidelines when sharing information. Agencies should ensure MHAD review as part of crisis and intake steps. During intake or crisis planning, staff should always ask if an MHAD exists and review its contents. This should be built into forms, workflows, and checklists. Agencies should also review how MHADs are being used. They should track how often MHADs are being completed, shared, and followed. This could be part of a monthly quality improvement process. Example areas for evaluation may include how many clients have an MHAD on file, whether MHADs were reviewed during recent crisis events, and to what level staff feel comfortable using them. Here are a few resources that can be used to help increase and enhance your knowledge about mental health advanced directives. To learn more about the topic, please click on the link in this slide to explore additional trainings. Here we have crisis support numbers, including the 988 Suicide and Crisis Hotline, the Native and Strong Lifeline, and the Native Resource Hub. And here is a list of resources that offer connection to Washington law and federal links toward webinars, trainings, and best practices in the world of mental health advanced directives, also known as psychiatric advanced directives. If you have questions, please contact HCA at the link above, and also check out the HCA Mental Health Advanced Directive webpage. Thank you.